Hello, everyone. Just want to thank all of you. I hope you have had a very informative and enjoyable day today. Certainly hope that the conversation that we're about to have will be not only informative, but also inspiring. I'm Tracy Matisak. I will be serving as the moderator for this conversation. And I have to tell you that as I was talking with some of the panelists that you will meet in just a moment, I was so excited about and impressed with the work that MFHS is doing in this arena, particularly this maternity medical home care model. I think they have figured out what healthcare should look like in America, and they are doing it in a way that I certainly hope we'll see replicated across the country at some point. I also think, having listened to Jill's remarks just a few minutes ago, that what they're doing addresses so many of the concerns that she shared with us. So we hope that you will enjoy the conversation. We've budgeted a few minutes toward the end for your questions for our panelists. So if something occurs to you as they're talking, just make a note of that, and we'll save a few minutes at the end for that conversation. That said, I want to introduce our panelists, and I'm going to ask you, panelists, as we sit here in our very Oprah-like setting, I'm going to ask you, as I introduce you, to raise your hand. There's quite a number of them, as you can see. So I'm just going to ask each of you to raise your hand as I introduce you. And let me start with Laurie Waskovich, who is a registered dietitian and the Nutrition Services Administrator at MFHS. She's also a certified lactation consultant for the WIC program, providing education and support to improve the health and well-being of families. Laurie Phillips is the Nurse Family Partnership Home Visitor with MFHS. Her nursing career includes many years of experience in labor and birth, as well as substance use disorders, and she is also a certified addiction registered nurse. Kristen Jenkins is the lead nurse practitioner at MFHS with a specialization in reproductive care. Nicole Collins is a licensed clinical social worker and is certified in perinatal mental health. We'll be talking about that in a moment. Angela Zaino-Hallock is a public health. Hello, everyone. Just want to thank all of you. I hope you have had a very informative and enjoyable day today. Certainly hope that the conversation that we're about to have will be not only informative, but also inspiring. I'm Tracy Matisak. I will be serving as the moderator for this conversation. And I have to tell you that as I was talking with some of the panelists that you will meet in just a moment, I was so excited about and impressed with the work that MFHS is doing in this arena, particularly this maternity medical home care model. I think they have figured out what healthcare should look like in America, and they are doing it in a way that I certainly hope we'll see replicated across the country at some point. I also think, having listened to Jill's remarks just a few minutes ago, that what they're doing addresses so many of the concerns that she shared with us. So we hope that you will enjoy the conversation. We've budgeted a few minutes toward the end for your questions for our panelists. So if something occurs to you as they're talking, just make a note of that, and we'll save a few minutes at the end for that conversation. That said, I want to introduce our panelists, and I'm going to ask you, panelists, as we sit here in our very Oprah-like setting, I'm going to ask you, as I introduce you, to raise your hand. There's quite a number of them, as you can see. So I'm just going to ask each of you to raise your hand as I introduce you. And let me start with Laurie Waskovich, who is a registered dietitian and the Nutrition Services Administrator at MFHS. She's also a certified lactation consultant for the WIC program, providing education and support to improve the health and well-being of families. Laurie Phillips is the Nurse Family Partnership Home Visitor with MFHS. Her nursing career includes many years of experience in labor and birth, as well as substance use disorders, and she is also a certified addiction registered nurse. Kristen Jenkins is the lead nurse practitioner at MFHS with a specialization in reproductive care. Nicole Collins is a licensed clinical social worker and is certified in perinatal mental health. We'll be talking about that in a moment. Angela Zaino-Hallock is a public health dental hygiene practitioner with advanced education in performing complex hands-on clinical procedures. Maria Cimini-Bello is a community health worker and maternal child advocate. And Melissa Yarmey is the practice administrator at MFHS. So please join me in a warm welcome for all of our panelists. So, Melissa, let me begin with you and ask if you would just give us kind of a high-level overview of the services that MFHS provides in this particular integrated care model and what it offers to patients.
I'm on. Okay. So MFHS Circle of Care offers pre- and postnatal comprehensive care based on the Healthy Beginnings Plus model, all in one location. So at our Circle of Care, we offer the WIC program, which is not only healthy foods, but we also offer nutrition and lactation consultation. We have the Nurse Family Partnership Program, which are in-home nurse educators from prenatal through a child's second birthday. On the site, we actually have in-site laboratory and ultrasound. So in addition to your OB clinical visits, you can have your ultrasound visit and your lab visits there. We also provide in-office education as well as education classes free to the community on site. We also have through Angela, who is a PhD-HP, I got that correct, and Dr. John Cimini, we have oral care for our patients. We actually also have a team of behavioral health consisting of licensed clinical social workers who can offer mental health therapy there. We also have Maria Bello, which is our maternal child advocate community health worker, and she is able to help patients navigate services inside and outside of the agency.
So there you have it, pretty comprehensive
I
suite
think
of services, right? And that gives us plenty to talk about. And Kristen Jenkins, I'll go to you next. If you could tell us a bit about your role as a nurse practitioner, and then also if you would talk about some of the biggest gaps that you see the patients and their families experiencing when it comes to like traditional prenatal or postpartum care. Like, what do you see most frequently?
Okay. All right. So I will actually start with saying I've actually worked at this organization for 19 years I'm coming up on. So I really believe in the mission and what we're doing here. And our CEO is very supportive of maternal health outcomes and having good experiences for expecting moms and babies. So I really appreciate all the support that she gives us on the clinical level. So I wanted to start there. And I have worked here because of all the services that we can provide our patients. So as a provider, and again, I've been here 19 years, like I love the fact that I've seen patients like as young as 12 or 13, and I've watched them grow throughout their, their reproductive years. They get married or they have babies. So it comes like full circle. What else were you asking? I'm sorry.
Just about the biggest gaps that patients experience.
Okay, so what I will say, before we had this medical maternity home, we used to have a different location. And it was, for our patients, a lot of times, like they were missing so many of appointments. They were not getting their prenatal labs or ultrasounds. Again, because of lack of resources, a lot did not have transportation. They had no way to get to the office. So once we instituted this medical maternity home, and the medical Uber has been fantastic because I think our no-show rate has decreased drastically since we've implemented that program. So that helps patients make their appointments with us, as well as we'll Uber them even if they just need lab work. If they need to get to maternal fetal medicine, we're actually able to facilitate an Uber ride so they're not missing those critical appointments. So it helps us like manage and co-manage again with maternal fetal medicine when patients are making the appointments now because of this medical Uber that was not there. And with this medical maternity home, again, we didn't have lab services. When we started integrating it, I think it's rare that patients don't get blood work, but prior to that, they would be going to labor and delivery without having any lab work done because they just couldn't make it to the lab. So having that option in the office is amazing, as well as ultrasound. So as soon as they come for their first prenatal appointment, before they even see me, they get that ultrasound. So they know that they're having, if the pregnancy is good, they find out right on the spot, and I discuss their ultrasound findings right there with them at their first appointment.
Great. Nicole, I had not heard the term until we had some conversations prior to today, perinatal psychology or prenatal psychology. Can you talk a bit about the importance of behavioral health during pregnancy and postpartum. And tell us about this term, because this was new to me and maybe not to everyone in our audience, but I don't know that the average person has heard of that term, perinatal psychology.
Yeah, so it's really, it's a very important thing that was not talked about for a very long time, but it's really important because it aims to improve the health of the whole person. So we're not just looking at the pregnancy, we're looking at them as a person. So everything that they've been through, everything that they're going through, even past traumas, that really plays a huge important role in the pregnancy and postpartum for sure. So everything that we're able to do at MFHS really focuses on the person themselves, but then their family systems and their dynamics. And so we're able to just be there with them throughout the whole process from beginning to postpartum, because again, postpartum goes all the way up to a year, sometimes 2, and a lot of people are forgotten about after their 6 weeks and everything. So it's just definitely very important to address everything as a collaborative team and just make sure that they are well supported, because that'll help. You know, it is relatively new-ish, I guess you can say. I know that it has dated back. It's started in 400 BC is what we had found. But in the 1900s is really when it started to kick off, and it was in the United Kingdom, which is where it started, and that's where the EPDS came out, and that's the Edinburgh Perinatal Depression Screen. And with that is when they came up with, that's the screening tool for perinatal depression, and that's really where they started to focus on everything. But in 2000s, that's when PSI came up, and that's when really postpartum started to really give its, the big emphasis. But I just feel like even now, within the last couple of years, we've made so many strides in just kind of getting collaborative and really focusing on mothers, and again, not just them in the here and now, but them with their traumas that are being brought back up in pregnancy and postpartum.
Yeah. And I don't know about you all, but when you think about just the hormones during pregnancy, and you think about the anxiety and all of the things that are swirling around, those of us who had our children a long time ago are saying, where was that when it was my turn? Let's go next to Angela. And Angela, if you would talk about why dental health is so important. I mean, it's important all the time, but why is it especially important during pregnancy?
So to me, oral care is part of overall care. So if we're not treating your mouth, and that's the gateway to your whole entire body, then we're not giving overall care to our patients or comprehensive care. And during pregnancy, it's been found that the bacteria in your mouth spreads through your body. So it is linked to preterm and low birth weights. So if we can decrease that bacteria load, then we can help those numbers, and we can help the mom facilitate healthy habits along the way, too.
Yeah. Do you see patients who maybe don't have their own dentist, would not even be aware of something like that bacteria can have an effect?
Yeah,
in the
most
pregnancy?
of our patients haven't had dental care 5, 10, 15 years ever. A lot of our patients have only received dental care when they're in pain. So then they have that negative aspect of dental care, and they associate it with pain. So we're able to get them in for preventative appointments, give them a positive experience, and then set them up to see them every 6 months instead of it being 5, 10, and 15 years.
Yeah. And Laurie, you are the person to talk to about the nurse-family partnership. So tell us a little bit about that and how it helps to support patients during their pregnancies.
I feel like we are one of the most under-recognized programs out there. I don't think that people are aware that we've been doing this for 25 years. So I have some cheat notes just so I don't forget anything. Yeah. So Nurse Family Partnership is a free evidence-based home visiting program that we support first-time and other pregnant moms from early pregnancy until the child's 2nd birthday.
I'm going to ask you to hold your mic just a little closer, Laurie, to make sure we can hear you.
Okay. We provide holistic perinatal and community health nurse supporting mothers and their families, particularly in communities affected by social and structural and economic insecurities. Our biggest things are we're offering guidance on pregnancy health, parenting, child development, and attachment. And our program really emphasizes empowering personal decision-making and fostering long-term care for their well-being.
Yeah. So since we've been talking about kind of a one-stop shopping model with integrated care, so explain how the home visit component works within that.
So when we begin our visiting, it's usually first trimester, but the patient just really needs to be pregnant. When we're going into these homes, we're doing hourly visits. We do them weekly or biweekly, and that's again over 2.5 years. So we become very close with our clients. We're guiding them on healthy pregnancy, nutrition, and prenatal care. We're preparing them for labor, delivery, and postpartum. Support with breastfeeding and or bottle feeding once they come back. We do have some CLCs that are within the nurse-family partnership. Advice on child health, safety development. We help with parenting skills. We help them set goals and reach those goals. But our main focus is teaching our clients how to do things on their own, empowering them. So when we leave, they have those tools.
Yeah. And so, and one last follow-up to that. So is it, in addition to, like, is it an additional service that patients who are seeing all of these other panelists can take advantage of, where they can also have a nurse visit them? Or is it more for patients who, let's say, are in rural areas and just don't have the transportation?
So really, any woman who is at high risk is available to us. WIC, Maternal Family Health Services, we get a lot of referrals through them, but other OB agencies in the area do refer to us, or if somebody's just word of mouth or calls themselves, they can also be involved in our program.
Okay. Maria, you are a maternal child advocate. Can you tell us what that is and how your role fits into the larger picture of patient care?
Yes, absolutely. So as a maternal advocate, I help our patients get access and the care that they need to obtaining the appropriate resources to help them get a better lifestyle, healthier pregnancy, healthier and happier postpartum period as well. That could mean as far as letting them know what resources we have right there at our Maternal and Family Health Services location at Circle of Care. It could be as far as getting them on-site counseling, getting them set up with WIC, dental, Uber appointments to get to and from their appointments. And it can also mean getting them set up with resources in our community. Many people, whether they're new to this area or maybe they're just not familiar with everything that's out there that can assist them. They might be going through a difficult time. That could be as far as obtaining housing, like I said, transportation, where our local food banks are, where they can get baby items that they may need. And so my job is to help them know what's out there for them, and that helps them lead to a healthier lifestyle, healthier pregnancy, and for them, for the mom and their families.
Yeah. Let's go to Laurie. And Laurie, you are a nutritionist. Talk to us a bit about how you counsel pregnant moms as it relates to their nutritional needs, especially during pregnancy.
Okay. So I educate the pregnant ladies using evidence-based nutrition materials from the Nutrition Care Manual and the Academy of Nutrition and Dietetics. But most importantly, you know, I give them the materials and we go over it. But the first part of my education with them is determining, you know, where are they in their nutrition journey? How are they normally eating? I'll do an assessment with them, determine, you know, what kinds of foods they're eating, what do they have access to, what do they like. There's so many, everybody's so different when it comes to nutrition and what they think is, you know, good and not good, and their thoughts about all of that. So I start with them, and I try to provide them with the best, the most, you know, accurate nutrition information. But sometimes it's about little things that they can change or improve, you know, for them, and that might be different for every single person.
Yeah. Melissa, I want to come back to you and ask you about what are like some of the biggest challenges that you would find as an administrator when it comes to coordinating so much care and so many different services under one roof.
So my biggest challenge is that I always have 47 tabs open in my brain and 2 are constantly glitching. Like I just have, it's being on top of everything all of the time. So there are a lot of challenges to coordinating. One thing I will say though, instead of looking at challenges, 2 things that really ease the pathway for us are 1, communication, and secondly, listening. if we're all up here and we're all being very buttoned up and we're being very formal, and if you ever come to COC, that's not what you will find. It's a very open, communicative, loud, happy environment that everybody's working together. And I think there are many challenges. Challenges of people working with patients who really need care and have a lot of serious issues, and it can get very heavy. So we work together to keep it light. And I do think communication is really important. We have really good communication with our WIC staff, which is right across the hall. They're wonderful. They come back and forth all the time with issues for patients when Laurie can't physically be there. Nurse-family partnership is very communicative with us, that when they are out in someone's home, if they discover something or see something that we need to know about that maybe isn't clinically that the nurse practitioner would discover, but we need to know about, they make us aware of that. So I think, yes, it is difficult to organize everything, and I tell everybody all the time, I can only do as well as the team that I have, and we have an amazing team there. So I give so much credit to all the people, how we all work together. I think that's really, really important. We listen to one another, we collaborate, we communicate.
Yeah. Kristen, Melissa just mentioned that there are patients who have some serious issues going on. And I wonder if you could talk about, chronic diseases that you might see in some patients, be it diabetes or something like that. How do chronic conditions, maybe hypertension, impact pregnancy? And also, how does an integrated model like this one help patients to manage those kinds of conditions?
Okay. So actually, one of the biggest, I will say, high-risk diagnoses that we manage is hypertension, whether it's pre-existing hypertension or it's gestational, meaning that it developed during the pregnancy. So we actually, I think we got a grant. It was the blood pressure grant. So we're actually able to have the patient sit down with a nurse. They're actually given a booklet and parameters, and they spend a really good amount of time counseling the patient on blood pressure, when to call the provider, what's an emergency, when you should seek urgent care at the hospital. But in addition, those patients then are sending their blood pressures electronically to the nurse, who will then alert me hey, go look in this patient's chart, her blood pressure is trending high. So then I will then call the patient and maybe do a medication change. So, but hypertension is definitely one of the biggest conditions that we are seeing. And with hypertension, obviously it can increase the risk of miscarriage, birth defects, sometimes also gestational diabetes. They kind of go hand in hand. So with gestational diabetes, you worry about what's called macrosomia. That just means that a baby is growing larger than the baby should. Or sometimes women get what's called polyhydramnios, which is extra fluid around the baby. But hypertension also, it's something that's very challenging to manage, and we do collaborate a lot with maternal fetal medicine as well, and also Dr. Raven is a great resource too when we need him. But hypertension can also restrict baby's growth, and unfortunately, because I've been doing this a long time, I have had a patient or two, because their blood pressure wasn't well managed, that they ended up with a fetal demise. But thankfully, that's only been once or twice in my entire career. Yeah. But it's something that we do monitor closely. So when they are hypertensive, sometimes we'll even bring them in the office once a week just to monitor them closer, so that we are keeping on top of their blood pressures.
Yeah, and having that team approach can make a big difference.
I would not be able to do my job if I didn't have my team. I rely very heavily, even from the front staff. They are amazing at, hey, we have what's called Athena, it's a EMR system, but they'll send me a text, you need to, they'll alert me to something from the front end, as well as the nursing staff. They're incredible at triaging patients and alerting the providers as to what's going on.
Yeah. Nicole, behavioral health is, as you pointed out, critically important at any time, but certainly during pregnancy, and also in light of the maternal mortality rate. Jill talked about that a little bit earlier, particularly for women of color. I wonder if you could talk about the linkage between maternal mortality and behavioral health.
Absolutely. So when behavioral health goes untreated, it's significant, because there's women who are struggling eternally, feel alone, they don't feel like they have anywhere to go, so that's why the mortality rate is very high, and it's unfortunately suicide. But when it does go, there's that linkage, because when there's an early identification, like intervention, and they have access and they feel comfortable talking to people about what they're going through, then their mental health is being worked on and they're able to either get on medication if they haven't been before, or they're able to just feel heard and feel understood. And so it really does help and carry through. And what I do is I meet with them throughout the pregnancy, and then I do tend to follow them throughout postpartum. So they're just never, really left alone. And then especially with women women of color, I apologize. There's that stigma. They're very sometimes dismissed by doctors, and there's a lot of mistrust that they have in doctors because of how history, unfortunately, just kind of treated them and everything. So it's really just making sure that they too feel as one, and they're all part of us, and everyone deserves the same amount of support and attention and intervention, and to really feel safe enough. So I feel like what we do is we have a lot of people who just genuinely feel safe with all of us. So that is the linkage. And, when things go untreated, then unfortunately, mental health and chronic stress and all of that really just puts a lot of damage to bodies and everything. So,
Yeah. You talked about mistrust, and certainly there are, patients who have had bad experiences.
Yes.
There's also just the stigma around mental health that has been improving quite a bit, for sure, particularly among younger folks.
Yeah.
But how do you overcome that? In other words, how do you build trust with a patient who maybe had a bad experience or who feels like, oh, that's not for me? Like, that's...
Yeah, I do run into that a lot. And what I do is, the people hear the word social worker and they get so nervous that we're going to take their baby or something bad is going to happen. So we kind of veered away from that, and now we call ourselves perinatal counselors. And it's a softer approach. And usually when we do have somebody who says, like, I don't want to meet with her because I don't want to, and they're just very guarded, I'll just peek my head in and I'll just be like, this is just a meet and greet. I'm just saying hi, this is my card. If you ever need anything, we don't ever want you to feel alone. I know you said you didn't want to meet with me. It's totally fine. 9 out of 10 times, they tend to come back in a couple of weeks and they're like, hey, can we talk? Or I'll just see them in the hallway and I'm always like, hey, how are you? And it's like, you remember me? And I'm like, well, of course, and all of that. So I think it's, they come guarded because of their past experiences, but when they come to us, we are just a safe environment, and we're very friendly, and we treat them as a person and not as a number. And I think that unfortunately they're used to being treated as a number and not a person. So when they feel safe, then they start to open up, and then you gain that rapport. And I'm working with a lot of women now who at first were like, nope, I don't want to talk to you. But it's always because I'm like, okay, that's fine, totally fine. Here's my card if you ever need, So I think that's really how to overcome that, is make them feel heard, seen, not judged.
Yeah. Angela, I would ask you a similar question, because certainly you must have seen patients who either had a bad experience with a dentist before, just fear the machinery, the noise, the sounds, all of those things. What do you do to build trust in a patient who maybe has not seen a dentist before and feels very apprehensive about getting in that chair?
So dental fear is extremely common in the general public. But I do see a trend with our population, an extreme dental fear. And a lot of it is due to prior experiences. Lack of care, they're embarrassed, they think they're gonna be judged. Also, a lot of our patients had prior substance use, so that affects your mouth greatly. So that's their past being brought into the present, and they're embarrassed of that. They don't wanna be judged for that. Yeah. So when they come in, I let them not dictate the appointment, but take it at a pace that they're comfortable with. So if maybe the first visit they are only comfortable with doing x-rays, okay, we'll do the x-rays this visit, we'll bring you back for the cleaning next visit. Making them a part of the treatment plan instead of dictating to them, they're a team, like we're a team with them. Yeah. So they feel like they have some control over the appointment. Another thing is that I recently read a study where dental fear is actually increased for patients that have experienced any type of abuse, which is a large part of our population. And that could either be because they're laying back in the chair, they're giving up power, they don't know what's going to happen. So we inform the patient of everything beforehand, they're a part of the process, they know what's going to happen, and they have say in what's going to happen. So just working with them and being a team and letting them be heard can reduce that fear for them.
Yeah, Very similar to what Nicole was telling us, right, in terms of the approach and overcoming that. Laurie, I watched a video on the website, and it was various patients, discussing their experience, and the word family kept coming up on this video, and patients kept saying, I feel like this is a family. This feels like my family. They've given me confidence. They've given me, all of these different things. I would love for you to talk about how you all as a team work together to create that family atmosphere, and about kind of the intangibles that you see patients getting from being part of this care model.
Oh, absolutely. As you can imagine, 2.5 years with a client, seeing them every week, every other week for an hour at a time, you really become part of their life. Not only are we there taking care of them in a nursing aspect, but we are going over many parts of their lives. We do a strength and risk assessment. So it was broken down into both personal health, family, friends, maternal, environmental, life course, and health and human services. We're doing family history with them. We are having them develop goals and then helping them reach all their goals. We empower them one small step at a time is still moving forward. We celebrate all of their strengths. We celebrate all of their accomplishments. Sometimes we're the only person in their life in that 2.5 years that is actually there supporting them and cheering them on, or just the one constant person for 2.5 years in their life doing that. It is, it's hard when you get to the end and you're going to graduate your clients to think that they're not going to be part of your life either, because they do become our family as well.
Yeah. Maria, I have a couple of things. One is, no doubt you've got moms who have other children, and just having, other small children can be a barrier to getting the care that they need. And I know that this has come up earlier in the conversation, but I wonder if you could drill down a little bit on that and how you sort of try to cover all the bases, and how you help those patients who might have other children that in some ways might keep them from showing up for their appointments.
Yes, so here at Maternal and Family Health at Circle of Care in Scranton, we encourage them to bring their children and their babies. They in no way have to feel like, well, I can't get to my appointment because I can't find someone to watch the kids. That is not it. They are welcome. We encourage it. We are so supportive there that every staff member in there, trust me, will help out in some way. We will pitch in, as like dental, if like they have siblings, they can come back. We'll take them for they can come back in my office. I can take them for a walk, give them books, keep them occupied until mom is done with their cleaning, and so on and so on. And we tell them that up front. You don't have to leave your children home or your babies. Bring them in. That's part of our family dynamic that we have there. Yeah. Like I said, you are not just a number there. You're family. Bring your children. We want to see them as well. And then when I do meet with them, I can go over, like, do your children have, what do you do in a different situation? Maybe you have to go someplace. Do they have childcare? Do you know about these childcare services? Do you need help applying for them? Do you know when it's time to register them for school? Can I help you with that? Do you know how to go about that process? And so on and so on. So it's great to actually see them come in together and go over that. Sometimes it's not just mom that needs something or baby, it's the siblings as well. Yeah. So we work with the family.
So, and what you've done and what you're describing really is like you're taking away barriers, right?
Yes.
You're removing barriers to care, things that we might not even think of, but that come up and could be a small thing to most people, but something that keeps someone from getting the care that they need.
Exactly. Yeah. It could be a language barrier. And when they come in, we have bilingual staff, we have interpreters, and from there we can work with them. They, filling out an application. Yeah. Like, this is how you apply for daycare. Or this is how you apply your children for school and register them for school. And they might feel like they wouldn't even know where to start with that. So
I'm glad you mentioned that, because I was thinking of bilingual patients. I know, I grew up in Hazleton. Hazleton now has a huge Latino population, and it would be easy for patients who do not speak English to fall through the cracks. Exactly. But that's something that you've addressed.
Exactly.
Yeah. So removing barriers. Laurie, I want to ask you about the nutritional gaps that you see? Like, what are some of the biggest issues that you see nutritionally with the patients that you serve?
That's a good question. Like I was saying before, the gaps can be different for every person, but I think that, the financial gaps is one of the biggest financial problems, that they can't really afford to eat healthy foods, so that they choose things that they can afford. They might be shopping at the dollar store, or they might be shopping, eating a lot of fast food because it's convenient, because transportation to grocery stores is actually another issue too. Just like they have transportation issues to get to our appointments. Sometimes I go over a whole week food package with them, and I go into a lot of detail about what they could eat and what they could get, and then come to find out at the end, they can only go to the store once a month because they don't have a ride to the grocery store, or they might have to take an Uber to a grocery store, they might have to take the bus to the grocery store, and so they can only get things in small amounts. So that's a big barrier. So it's not just about nutrition knowledge, although that is a barrier for some. We have a lot of young patients who don't know how to cook, and who haven't grown up in a household where cooking is a big event like it is in some people's houses. So they don't know how to cook. Their parents didn't cook, the moms didn't cook, so teaching them how to make simple things can be helpful.
Yeah.
Can be helpful as well. Those are some of the big gaps.
Yeah. Melissa, does MFHS partner with specific hospitals, like when it comes to the actual birthing process? Because you've got the run-up and you've got the aftermath covered, but what about the actual birthing process?
So yes, at Circle of Care, we partner with Moses Taylor Hospital. So that is where most of our births occur. Occasionally there are some that need a higher level of care that need to be referred out, but we do partner most of our births with the Physician Health Alliance group, of which Dr. Rabin is a part of, and they have their babies at Moses Taylor, where they have a NICU.
Can you also talk, Melissa, about working and partnering with other community organizations and how that helps improve outcomes overall for patients?
So we do partner with a large number of organizations. Cindy Kennedy knows everyone. And I don't know how else to put it. So every organization in the area, we are fortunate to have some connection to. And I'll give one really good example. Cindy made a connection with Indigo Spoon, which is a small nonprofit. The person who runs it was a former chef, and she has a small nonprofit that she partners with us. She does pop-up food pantries with us, but she also provides postpartum packages, which are food packages that are approximately about $100 worth of shelf-stable groceries. And also she provides a homemade soup that we keep frozen at Circle of Care, along with usually a meat product, a ground meat product, chicken or beef, that when Maria identifies postpartum moms who are in need of this and would like that, as they're there for their visit, we can provide that for them. So it's not something that MFHS is providing, but a community partner is providing with us. So that's just one example, but we have many, many in the community that we see a need. Kristen identifies a need at a visit. Like I said, if NFP identifies something, WIC will come over and mention to us, they have their WIC food package, but they don't have groceries outside of that. What could we do? And we refer them to Maria, our community health worker, maternal child advocate, and she can hook them up with food pantries. People don't have baby items. Maria can do that as well, because we have so many community partners that reach out to us, and vice versa.
Yeah. So before we get to questions from our audience, I'd like to do something of a lightning round here, and I'm going to ask each of you to share with us either a success story of a patient that you've worked with, or just how you see this integrated model tangibly improving health outcomes for your patients. So either or, and we can go right down the line. Angela, I'll start with you.
So one patient that stands out to me is she was a patient on the OB side, and she was in extreme dental pain, 7 or 8 months pregnant, had reached out to different dental offices, and they refused to see her because she was pregnant, which is antiquated thinking. Some dentists don't want to touch you when you're pregnant. So their answer to that was they referred her to an oral surgeon's office. Oral surgeon's office in this area that take medical assistants are booked out over a year. So that's a mom that's in pain, she has swelling, she has active infection in her mouth. So her OB provider came over, consulted with me. We were able to get her right into dental. get her on antibiotics, get her on doc schedule. The tooth wasn't able to be saved just because it had gone so far, but we were able to pull the tooth for her. She was so grateful that she didn't have to think about that now. Like, it wasn't taking away from her whole experience of having a baby. So we were able to do that for her. And I mean, I don't know if I've ever seen someone so happy to have a tooth pulled, but she was so happy to have that infection and that pain out of her mouth.
Yeah.
So it really impacted me.
Made a
with that.
difference.
Mhm.
Yeah. Laurie?
Oh, sorry.
So through Maternal Family Health Services, there's a Kathy Dickerson scholarship that NFP clients can apply to, and they are our clients who are going to higher education. Last year we had 7 awarded just within the 2 counties. So I think that that is an amazing thing, and how we work together so well to support the community and our clients.
Maria?
Yes, so we had a patient that was newly pregnant. She had just found out she was new to the area, so she had no family support, no friend support, no support system at all. Does not know the area. She was very scared, no idea where to even begin. When she called to make an appointment, she didn't even have insurance. The first thing I did was walk her through, why don't you have insurance, and let's go over our options, and let's go, and come on in. Let's go over this application together. I have one here. Fill it out, send it over, apply for state insurance. That comes back. She gets that insurance. She's able to become a maternity patient. We offer her brand new maternity clothes from our program, which is Betty's Closet, which is another great program that we have where moms get new clothes. And I was able to connect her with WIC, which she had no idea how that even worked, because this is her first child. We set her up with on-site counseling. We got her a dental appointment for cleaning. So when all was said and done, she was one happy maternity patient, and that just made my heart happy, because that's exactly what it's about. So
That's why you do what you do.
that's why
Okay. Nicole?
So there's one recently that really just shows also how we work very well with, obviously, like other people in the community. So there was one that came to us. She was taking Suboxone, but it was a very small dose. She didn't want, nobody knows, and she was very nervous. And it took her a little bit to tell us about it, because she felt she was nervous she was going to get judged and everything. So when she finally opened up, she explained why she was nervous and everything. So we reached out to Healthy Moms and got her connected with Healthy Moms, and then Healthy Moms kind of put like all heads together, and then we figured out that we found a doctor in the area through Geisinger who would be willing to work with her and taper her down so that she would be able to come off prior to having the baby, but then also going over everything and just really easing her mind with that, because she was very nervous about that. And so she's now being seen with Geisinger OB. However, she's still with me behavioral health wise. So it's just stories like that where it's not just us. We're reaching out, to olive branches, to other people, and just saying like, hey, can we work together? Can we figure this out? But just also making sure that the mom and the family in general is just very well taken care of, and make sure that they, again, feel safe. I just feel like safe is such the term for everything, and not judged. And she's much happier. Her anxiety went down significantly. And again, she's being seen by Geisinger, but she's also coming to us behavioral health. So I just love the collaborative partnerships that we have, and just how everyone works so well together.
Okay. Laurie?
Yeah, I would like to start by saying that the participants being in the, let me turn this on, sorry. The participants being in the office, and me being there to do WIC with them when they have their OB appointments is really something that I get a lot of feedback on from the participants. I know I'm not there every day, but I have access to their schedules, in their medical schedules, and I have access to the WIC appointments, so I'm able to coordinate and try to get there be there as often as I can to tie their WIC appointment in with their OB appointment, so they come for the OB, and then I'm there and I put them on WIC. And like yesterday was an example of just like every person that came in was like, thank you so much for being here. Thank you for being here. I'm so glad I can do this today. And then I try to schedule them their next appointment when they have an OB appointment. They're like, that would be great. That's so great. Like, that's just a really positive thing. And just one quick success story I just feel about. I had a gal who was on her third child, and she didn't have success breastfeeding with her first two, but we worked through some of the barriers that she had, and there was some significant things that she wasn't aware of. And she called me after her baby was born and said she was breastfeeding her third child after not being able to breastfeed her first two, and she was so happy, and that made me really happy.
Yeah, it's wonderful. Melissa?
We recently had a patient who had mental health issues that she was seeing one of our counselors for, and during her pregnancy, she also came up with a significant clinical issue as well. She was not in a safe living environment, not physically. The father of the baby wasn't involved, but the actual home she was in. And because of those factors, she became, I'd say, more and more withdrawn. She did not want to participate in her care, and at times she made comments she didn't care what happened to the baby. I don't care what happens to this baby. I don't want this baby. I can't take care of this baby. She had 2 small children at home that children and youth were involved with, just because she was having such issues caring for her children. On our high-risk meeting, she was a topic of discussion quite a bit amongst her nurse-family partnership, Nurse Charlene, her social worker who was helping her, the provider, all discussing, like, everyone trying to reach out to her, how to get her. It came to a point where we actually had to involve the Scranton police because she wasn't responding, and we weren't even sure if she was physically well inside of her home. So there was a lot of communication back and forth. We had scheduled her to go for her section, I believe, more than once at the hospital. And Terry, who I talk to all the time from labor and delivery, and now we finally met in person today, she'd say, nope, she didn't show again. So it was very collaborative between MFHS, outside entities. The good thing is we were finally able to get her physically there to have her baby. She had a safe delivery of a healthy baby. I think the baby's APGAR was 9. And she's actually doing well now. She's thriving. Her 2 older children are in a safe environment. She has her little girl with her, and she's doing really, really well. She's following up with us mental health-wise. She's thriving when you see her. She came back into us to continue her reproductive health, and that truly was because it was such a collaboration amongst our team and outside entities as well. So I was really proud of that outcome. Thank you.
Kristen?
Okay. All right. So I think overall, like, the success with our patients also, I'm going to speak from, a provider perspective. So we're not like other offices where patients have to be seen every 15 minutes. So we actually have 30-minute appointment slots. So that really allows us time to actually get to know the patient, get to find out what's going on with them. Like, I can tell just because, and we see patients literally from their first appointment, like their prenatal appointment, they see the same provider throughout their entire pregnancy. So that really builds trust and rapport. And recently I had a patient, she wasn't gaining weight, so I kept talking to her every visit, like, what's going on? And she's like, oh, I'm just working out, I'm really anxious, I'm not sleeping. So she finally disclosed to me, like, she had an eating disorder, and she was 37, she never disclosed it her entire life. So I sat there, I talked with her thoroughly about it, and then I am so grateful to have social work right there, because I literally just walked her right over because I said, do you want to talk and get help today? And she said, yes, please. So I walked her over to the social worker, and I know that she's getting counseling. So I just saw her and her husband recently. She was smiling, and she said, I feel so much better. She's like, I'm eating now. I feel healthier. I'm sleeping at night. Her husband's other relationship's getting better. So just having that time, and sometimes, again, you just notice little things because you have that extra time with your patients. And then I also wanted to highlight too, we do a lot, our nurses, they do a fantastic job. It's called 4th trimester planning. So I recently had a patient, twin pregnancy, first pregnancy, beautiful pregnancy, like nothing wrong. Never had an elevated blood pressure, no complaints. She had her C-section, and 3 days later, like after being discharged from the hospital, because of all the education that she had received from the nurses on that 4th trimester planning, she called the office and said, I'm just really not feeling good. I have a really bad headache. So I'm like, come in now. And that's the other thing too. When patients call, like, I don't care. I double book myself all the time. I drive everybody in my office crazy. But to me, like, patients are our #1 priority. So I'm like, I don't care. Everyone's yelling. I'm like, bring her in now. So I brought her in. I could tell right away. I'm like, I just knew by looking at her. I'm like, she's got postpartum preeclampsia. Well, her blood pressure was like 180 or over, like 120. Called the hospital. She was actually admitted. and they kept her overnight. They gave her some medications, and then I saw her probably every 2 to 3 days for about 2 weeks until I knew for sure that blood pressure was under control. But she was so grateful. Her twins are healthy, and she was so happy that we actually accommodated and kept such a close eye on her. So again, I think it's really important to be able to have time with your patients and having a team that's going to support you, because you can't do everything by yourself. And I need my coworkers to make it a success, and this agency really supports providers in giving us what we need. So I'm very appreciative to work here. And I love, like I said, I love my patients. I'm very attached. Anybody who knows me, I'm very possessive and I get attached to my patients.
So on that note, let's take questions from any of you. If you have a question or a comment for any of our panelists, we have a few minutes if you'd like to follow up on anything that you heard. Don't be shy. Yes?
It's for Angela. I wanted to know, what is the range of services a pregnant woman it's okay or safe to have during pregnancy?
So they have found that dental care is safe throughout the entire pregnancy. X-rays are safe throughout the entire pregnancy. The safest trimester is the second trimester, but we will see them, get them any immediate care they need while they're pregnant, get them out of pain, get them infection down, or take the infection away from them. And then afterwards we'll do any restorative work that didn't need to immediately be done while they were pregnant. But they have found that it is safe throughout pregnancy.
All right. Well, how about then joining me in a warm round of applause and appreciation for our panelists for MFHS